Hello, everyone. Welcome to another exciting edition of the ELSA Surgical Spotlight. I'm your host, Dr. Sajid Malik, and we are diving deep into the one of the most evolving area of the upper GI, which is anti-reflux surgery. And to co-host with me, Dr. Amir is joining me from Qatar. And before we dive into the today's discussion, it's my great pleasure to introduce our distinguished guest, who is a true pioneer and true leader into the upper GI surgery. Please welcome Professor Assam Shabir. He is a senior consultant surgeon and chair of upper GI and bariatric surgery in National University Hospital in Singapore. And he has been instrumental in shaping the clinical pathway and surgical training in Asia Pacific regions. So this is our great pleasure to have him onto the board. And thank you, sir, for joining us.
Thank you very much, Sajid and Amir, for having me here. Truly an honor to be there with the ELSA TV and the ELSA group. I think it's a great opportunity to learn from each other. Thank you.
Thank you, Doctor. So also it's a great opportunity for us. And just I want to make a quick start because there are a lot of things to ask you. First, please, can you introduce reflux to the audience and explain why it is important and why it is commonly neglected?
So I think, thanks very much. That's a very interesting question. I think in the West, reflux has always been of high importance because of the known rising incidence of junctional adenocarcinomas, its relation to Barrett's esophagus, a precancerous condition, and leaving. In the Asia-Pacific region, reflux has largely been something that has actually resulted in poor quality of life. Wasn't so much pronounced, but as our diets now get westernized, we see a rising incidence of not only of people complaining of reflux, but also of adenocarcinomas, as in multiple publication. So overall, in general, for poorer quality of life and long-term survival and the risk of cancer, it is increasingly becoming something that we are looking into across the globe now.
Correct. So what are the symptoms that the audience especially should be worried about to seek any medical attention?
So in general, as you know, Amir, there are those typical symptoms of reflux disease for patients. And then there are the red flags that their clinicians would be looking at. And then there are the non-typical symptoms or the atypical symptoms of reflux disease. As far as the classical symptoms are concerned, there are two of this. One is heartburn, which different people describe in their own languages and dialects differently, from something hitting the back to a burning sensation, which largely in many populations would represent, in my opinion, the effect of the acid in the lower esophageal, in the lower esophagus, and gives that retrosternal behind the breastbone burning sensation. Mm-hmm. That's heartburn. Regurgitation, to some patients, this is probably a normal part of their life. I've had patients who come and say, oh, we never knew that it was actually not normal to not have regurgitation. They thought regurgitation was a normal part. So they can feel the taste of their food even hours after meal back in their throat, or they can regurgitate food. This is one of the other things that patients with GERD will complain. Then there are the atypical symptoms like cough, whether due to microaspiration, irritation of the pharynx giving pharyngitis, hoarseness of voice, and many even like running nose, basically food or gastric contents dribbling from the night and late at night, their inability to lie flat at night. And those atypical symptoms are important when we make clinical judgment. As far as our clinicians are concerned, when we look at patients, we look at red flag symptoms along with it. Like, has the patient been actually vomiting? And has the patient actually vomited blood? Is there melena, which is black, jet black, tarry, soft stools? Is the patient anemic? Is the patient having, excuse me, loss of weight or loss of appetite, which may indicate a progression from one stage to maybe a pre-malignant stage, pre-cancer stage to a cancer, or in more simpler forms, progression of a milder form of inflammation in the esophagus to a much more stronger inflammation, which then gives people that sensation and they don't eat, they don't want to eat. Yeah.
Right. So, doctor, as we know, still, OGD and barium still remain the mainstays of pH studies. But with the new consensus, which includes Lyon impedance pH monitoring, how do you interpret borderline or inconclusive reflux metrics, like particularly in patients with persistent symptoms?
Okay, so thanks very much, Amir, for that question. So first of all, we need to understand that the reflux disease is actually a spectrum of disease. It's not one disease. Then within the spectrum of disease, they are largely, I would classify them into three cohorts. When you do investigations, there will be those with erosive reflux, which means that the acid that reflux back actually damages the lower part of the esophagus, and the lining has changed to protect and change so that it can secrete water to protect that acid. And this basically then moves on to what we know as Barrett's esophagus. Then there is non-esophageal reflux disease, where non-erosive reflux disease, where there is acid reflux on investigations, but you don't see any erosions. Slightly harder to control with proton pump inhibitors in this case. The third category is where reflux is normal. So like everybody in this room, we all experience reflux maybe on daily or weekly basis, but that is natural, and the body defense mechanism like peristalsis, swallowing saliva will clear this reflux. So reflux is not totally all the time abnormal. We all have certain degrees of reflux. So when this happens in this patients, even the normal reflux, the lining of the food pipe is so sensitive that it gives them a sense of reflux very strongly. So now, if we look at these different combination, then the combination of investigations available to us are also different. As you said, symptoms of patients, they're different scoring symptoms, and they may score very high on it. Endoscopy may not be, there is no concordance between reported symptoms and endoscopy. Mm-hmm. Even barium. So if I look into those, I think symptoms are important. That is why patients seek our help to help them. So I would always regard them as my top priority in treating my patients. Endoscopically, what are we looking for? We're looking for three main things on endoscopy. Is there a cause, a mechanical cause for the reflux? What is the pathological damage that the reflux is causing, and how is the extent? Is it just to inflammation, or has it progressed to Barrett's? Things like pH manometry, to me, are adjuncts to basic investigations. If you don't see any erosion, if you see just that, oh, there is the patient having a lot of symptoms, but I can't see, then you can do pH studies. Whether you do it with Bravo or impedance, Bravo will only give you acid reflux. The classical 24 pH, where there is a probe down the nose, can give you non-acid reflux as well. So if you're trying to distinguish acid versus non-acid, then probably 24 hours proper probe is a better option. Then you mentioned about barium exactly. Barium is largely to look at is largely to look at mechanical issues. Does the food actually reflux back? Can you see it going up? And can it come down back after that? And how good is the clearance? So these are some of the nuances, and they need to be taken into consideration and ordering these investigations along with the symptom of the patient, in my opinion.
True, doctor. And doctor, actually, as you know, we have seen that esophageal motility disorders are increasingly recognized. And how have new techniques and tools changed your preoperative workup and for the anti-reflux procedures?
So I think there are nice algorithms that have come out of the American Society of Gastroenterology, and many other people have actually published nice algorithms. What is the basic principle? The basic governing principle is that the patient has symptoms. We're trying to treat the symptoms. And if the symptoms are not getting better, why are these symptoms not getting better? So I think most people, for at least for the younger cohort with no red flags, will say that, oh, you just empirically treat it for 8 weeks with proton pump inhibitors, and that is a treat and test strategy. If patient symptoms resolve, maybe it was something related to stress or whatever, you get rid of those inciting features, including obesity, and if they get better, then that's it, you're done with it. Now, if you go up from there, most of us will now do an endoscopy. To look at the anatomical layers of the stomach, to look at whether there is erosion, is there gastritis, is there hiatal hernia. We all agree, we report hiatal hernias now based on Hill's grade. Is there really a mechanical issue? And look for gastritis, Helicobacter pylori infections, look at medications and all that stuff. And then if you find that, oh, patient has symptoms, the endoscopy is perfectly normal. You don't see any erosion. So now what do? Is this reflux? Is this not reflux? You are not really sure whether the sphincter is good or not. You may want a barium study. Right. It comes back, okay. Now, how do you prove that this is reflux? You can ask for pH study. And if the pH study comes back, oh, it's normal, then I would naturally progress to do a manometric study. And that manometry is a high-resolution manometry. Over longitudinal time, it gives you what is actually really happening with the bolus of food that is going down the esophagus. Is it really the esophagus can propel this bolus of food into the stomach nicely? Or is the peristalsis deficient? That information can come. It can tell you whether the patient is during pH studies, whether the patient is actually subconsciously having aerophagia, swallowing air, and having supragastric belching. And that's resulting to the symptoms because the esophagus keeps getting showered with acid all the time. The patient belches and bloats. Some people have this unconscious intention of trying to eat up air, drinking Pepsi colas and all these colas with a lot of air, causing gastric distension. And this then makes it a little bit complex to interpret. And that's where motility comes in it. And for me, if the motility then comes normal, I would then consider doing even more further functional studies of the lower esophageal sphincter and the gastroesophageal junction complex with investigations like endoflip. Yeah. And endoflip in real time, beyond a normal esophageal sphincter, will tell you whether the junction as a whole is compliant or not. Is it a little bit more relaxed than normal? And is it still then allowing reflux? So there are these advances that we can count upon, and that's how I interpret for supragastric belching. You send them for breathing exercises. For motility disorders, you know, although the data globally is not there for those patients, but if they have only pure motility disorder but no reflux, then you don't need to operate. You don't need, your PPIs won't be effective. They need motility drug supports.
Thank you for the very detailed insight into the investigation and leading towards the management plan. Prof, I have a question. Like, if you, there's always a pendulum between, as you rightly said, patient-reported outcomes and the motility. You need to decide between where exactly and which direction have to go. So, what you are thinking about the offering your patient a partial wrap or a complete wrap? What you decide pre-operatively or per-operatively in patient, in which category you will do a complete wrap or the partial wraps?
Okay, that's an interesting question, and I think it's been a question of debate for a very long time. I think the first thing is it is important to treat a patient and not an investigation. Okay, that's something that I come very clear with. If the patient is asymptomatic, has a motility disorder, leave him alone. If you can't support him, don't make it worse for him. If it's got eosinophilic esophagitis, then treat it and he will be well. But now, if you come purely to motility disorders like weak swallowing or absent esophageal peristalsis and fundoplication, actually, even data on Nissen fundoplication, which is studied the most, does not show that it really leads to significant dysphagia in this cohort of patients. Food boluses still pass. If their symptoms worsen, it is just a worsening of the motility and not the wrap. And this I'm talking about the loose wrap, the new Nissen fundoplication, which is not so tight. The good old classical Nissen fundoplication might have been a bit tight, where dysphagia rates were higher. And yeah, so if you really want to boil down to the nitty-gritty grades of the literature, then what literature shows is that tooth-paste fundoplication has the best balance in long-term follow-up and systematic analysis. The only difference between the three fundoplication is that tooth-paste fundoplication offers, for a trade-off of dysphagia with reflux, a better advantage over the two procedures. So a bit more balanced, but that's the only difference.
Nice, thank you. Another question is about the large hiatus hernia. I remember when I did fellowship with you, you used to use the pledget, PTFE pledget for the hiatus repair. What about using the mesh? And then recently I come across a new paper which was published and said that gastropaxy help in reflux during the hiatus hernia for the prevention of the wrap migration. So what you are saying about using a mesh in the large hernia or a gastropaxy as a concomitant procedure with the large hiatus hernia repairs?
Right. So you bring up interesting points. So this is largely related to surgical technique. Now, let's get something very, very clear. We know a lot about the mechanical forces that govern the GE junction, right? But we still know little. We don't know a lot of it. And just by the fact of what we have discussed, medications, patient-reported outcomes, different investigations, different procedures, different mesh, just goes to show we are not really sure of what's going on, right? And we are trying to tackle the problem from multiple angles, just like obesity. We're not getting to the root of where things are, okay? Now, it is interesting, and this is my observation. I may not have hardcore data to support that, but look, the esophagus has two muscle layers. It has a circular layer, and it has a longitudinal layer. The circular layer squeezes and propels the bolus forward, whereas the longitudinal layer contracts and makes the traveling of the bolus longer. So one is squeezing, one is shortening, and that is how peristalsis happens. How can you leave an organ which can naturally shorten, not anchored? If you leave it unanchored, it will shorten, ultimately go to its natural resting state where the muscles are totally in an uncontracted state. In a totally contracted state. I mean, how many of us have done total gastrectomies? If you see the esophagus is just nice, you have 4 centimeters, 3 or 4 centimeters. The moment you cut the esophagus at junction, it springs back. And then it is somewhere in the mediastinum and you're always struggling to bring it back. That is the natural recoil that nature has given the esophagus for functional reasons and other reasons. So when we do when we look at the junctional complex is composed of multiple things. It is composed of the crura that are there. It is dependent on the competency of the lower esophageal junction, the proper innervation, the phrenoesophageal ligaments that anchor the junction at the hiatus. Okay, it allows me and you, even normal people, have a 2 centimeters up and down translation. That is nature's way of allowing for compensation. Yeah. So when it is exaggerated, when the ligaments become weak, when the sphincter becomes weak, when the crura is no longer supporting, when the nerves are paralyzed or not functioning properly, people will then get reflux. So now you've brought the point of discussing the crura. What is it in the crura that makes it? The crura basically needs to abut that esophagus to provide that strength to that lower esophageal sphincter. If we can approximate the crura, people have done all sorts of things, from just simple suture approximation to putting meshes for bigger hernias, and like in Professor Demister's unit, even doing a slit on the diaphragm and then closing the 2 crura together and putting a mesh on this side. One can argue, is there a role for mesh repairs in large hernia? If you can't close the defect and you're really in a position that you can't close that defect and it's inevitable, maybe something to consider. I would say something to consider, at the expense of the fact that in the future, this mesh may erode into the esophagus. Thus, the mesh should not skirt the esophagus. It should be used purely lower down where crural approximation has already happened or is deficient to close, but should not come in contact with the esophagus. Otherwise, it will erode.
Like the people use the U shape, and it is in contact with the...
Exactly. You can use your U shape, you can use your keyhole. Now, choices of meshes, people, absorbable, non-absorbable, and all this. What is the whole purpose of all these meshes? Because these patients, we know, hiatal hernias, like inguinal hernias, are defective collagen and fibrotic tissue deposition, is to basically trigger fibrosis so that there is deposition there, right? So that it doesn't open up and it doesn't cause further problems to the patient. So is there a real difference between absorbable, non-absorbable? I read an RCT, there is no difference. So maybe in my way, a long-term non-absorbable mesh, if inevitable, really inevitable, I may use it, may consider it. And otherwise, generally not. I tend to rely on the Teflon. The Teflon is a softer material. It does not, I've not seen it erode. The Teflon plagettes that you have seen me put. Now, let me bring it, and this is just for crural closure that I'm going to say. If you look at the Australian randomized control trial, that showed no difference in how you basically, which technique you use. The one important message that trial carried was, how do you close the hiatus makes the most of the difference. And when they define that measure, what they define is that on the right crust of the diaphragm, the muscles are oriented in a longitudinal fashion. And if you denude it of its peritoneal, retroperitoneal lining, and you put sutures through it, it would just cut through like butter, like ceton. And there is no point putting it. Right? So the first principle of dissection is always to maintain that nice layer. Many people don't adhere to that principle, and that's why experience recurrence. In order to further buttress it, in order so that when I go out and it doesn't tear, I put these little small Teflon pieces in my sutures, which I do interrupted with ethibond during crural closure, and it just helps enhance the deposition of fibrin material. Last but not the least,
Mhm.
it is important to understand that we need to create a balance on how we achieve a crural closure.
Mhm.
If you take a heavy bulk of the cruras and bite big bites on both sides and tie them very tightly to each other, you're not achieving approximation. You're barely causing a lot more of fibrosis through ischemia, and the suture will cut through. So all you need is the two crura to come together with naked, non-epithelialized surfaces, which when you cut the peritoneum already develops without denuding the crust, a new fibrotic layer will form.
Yeah.
And this will cause adhesion and give you a great outcome.
Good outcome as well. Right. Thank you. Thank you. I'm going to touch another debatable topic about the on the other side of the spectrum. Instead of the large hiatus hernia, for the small hiatus hernia, when there is a lot of debates going on, magnetic sphincter augmentation with the LINX device. I remember you doing LINX. I assisted few as well. So, how has your experience evolved with the LINX devices in terms of the patient satisfaction and complications like dysphagia and long-term durability? So what do you think about it?
Yeah. So, Sajid, it is important that we know that why do we operate on these large hernias? We largely they do have some reflux symptoms, but they have more symptoms due to obstruction from the stomach that has herniated above, right? And then there is always this risk of torsion and occlusion, and that's why we treat them. For the smaller ones, they are largely symptomatic. They have heartburns and all those. Those are mechanical defects. And yes, true enough, we are one of the earliest centers with probably the largest experience at the moment in Asia for LINX device implantation, which is basically a magnetic sphincter augmentation device. Now, I've inserted these for primary patients with a reflux disease, and they seem to do well. The mechanism of action is not augmenting the sphincter by the force that the magnetic beads generates, but by the possibly the crown of fibrotic tissue that forms and reinforces that crural apposition that you and me see. How has my experience been? It is a gratifying experience. But there are caveats and there are learnings that I've had from this. The first learning I had from this is, like obesity, reflux continues to remain an evolving disease. Some patients would respond very well. Others may respond well. Others may not be satisfied. Okay? And if those group who are not satisfied for two reasons. A very small percentage of them continue to experience reflux and would require medications. So now I tell my patients, as opposed to before, that this is not 100% solution to your problem. You may intermittently still require therapy. Medical therapy, and that's what the literature also states. A bigger portion of the problem is dysphagia. As you know, it basically, the device once implanted offers resistance at the gastroesophageal junction for bolus of food coming from the top and passing down. In these patients, first of all, by default, I do a manometry to make sure that they are able to. We are investing into younger patients for very long periods of time. So if they don't have good esophageal motility, then I would shy away from making a definitive recommendation. Though data says that weak is still okay, but I generally may shy away. In the place that I live in and practice in Singapore, the main source of carbohydrate is not bread. It is rice.
Yeah.
And rice in this part of the world is sticky. I have heard this from some of my patients, and they find eating sticky rice a bit difficult. And when they eat it, that bolus kind of does not roll through that sphincter easily. I've had to explant, to be very honest, one device just because of that. They need to drink a sip of water. The other thing that I've observed, and a lot of people will tell you from their experience, is you need to go bite size. You need to eat one bite, need to wait for that to pass down. If you go one after the other and you gulp eat, everything will just come out because the peristalsis will not be able to push the food against the column of food into the food pipe. It becomes very tough, and most of them will find their way to the bathroom to know they're going to vomit it out. So these are some, but in general, my experience has been it's a good alternative to fundoplication or complementary in some cases, and has pros to offer, but also comes with cons.
Thank you. Thank you so much. Yeah.
So, Doctor, I have a question also. So I just wonder, in patients with post-sleeve gastrectomy, do you favor conversion to bypass, or do you prefer links or a tailored wrap for the selected cases?
Thanks very much. You bring us into a zone full of controversies. All right, so I have some experience in putting LINX devices for patients who are post-sleeve gastrectomy. I think there are a few things we need to understand. When we do sleeve gastrectomies, the technique is very varied. From people using as small as 30 French bougies, going as far as 56, 58 French bougies. What is that doing? I'm not talking about in terms of satiety and all that. I'm talking about in terms of mechanic. It's an outlet obstruction, right? So if your esophagus is 2 centimeters in diameter and it meets a 1 centimeter channel, which is about 30 centimeters long, it is causing a huge resistance, right? And Poiseuille's law basically governs that, and you can see that the relation to the radius to the flow and the resistance. So how does the esophagus then react? The esophagus reacts by compensatory dilatation. From those of you who have practiced in the band era, the band is purely an obstructive procedure. What happened to these guys? They got dilated esophagi. They were storing food in the esophagus. Food was there. They were getting esophagitis. We were loosening the bands, taking water out, trying to get the esophagus back into shape. What happens is that, like intestinal obstruction, nature will fight. It will contract, till a time comes it learns that this guy is useless. It's not going to fight against it. It will start dilating and distending. And then that moves the esophagus into the next stage of disease, which is called an end-stage esophagus, where it loses its ability to peristalse. Okay, why is this background important? It is important to understand that implanting LINX in patients with failed or failing esophagus is counterproductive. Why? Because if they have fluid coming back into the esophagus at night from normal reflux, it does not overcome the power of the LINX device. It stays there. Whatever little erosion is there, its exposure time to that acid is very long, and they become more symptomatic. Okay? If you want to implant it, my advice is implant it when the esophagus is normal. Treat the esophagitis aggressively as much possible to a normal esophagus, because if you treat it, if the patient has esophagitis, there is edema. And as you know, the LINX or the magnetic sphincters are deployed or measured using a measuring device which tells you how many bead device you're going to deploy.
Yeah.
Once you do your cruroplasty in these patients, the edema will decrease, the device may loosen up, the patients may land up having more symptoms. If you over tighten the device, they will have dysphagia and they will get what I described earlier. So my preference is, if I do them, I will treat them aggressively, bring them to as far normal as I can, and do it within 1 to 3, and on a preferential basis, maybe less than 5, but years post-sleeve. But I will do a manometry to study the function of the esophagus. If it is weak, I will not implant a LINX device. My default is to convert to a Roux-en-Y gastric bypass. So that's how my own personal decision-making treatments.
It was very clear. So, doctor, how do you approach for the patients with severe delayed gastric emptying or gastroparesis and reflux symptoms? Is still the fundoplication is an option or not?
Interesting. So, Amir, let me bring you back to basic physiology again, because we need to go back and reference that. So, what does gastroparesis do? Basically, there's poor motility in the stomach. If there's poor motility, what will it do? It will cause the stomach to distend. If the stomach distends, what will it do to the lower esophageal sphincter? The TLRs in the esophagus will increase. Transient esophageal sphincter relaxation will increase, which means the number of episodes of reflux will increase, and patients will be more discomforted. Now, we need to study whether this is a global dysmotility in the stomach, or is this something that is treatable? How do you do that? You can actually ask for a 4 hours gastroscintigraphy, and it will tell of solid meal, not liquid meal, of solid meal. It will tell you what the clearance is, T-half of the barium loaded meal is like. When you do that, and if you find that there is gastroparesis, then look at how is this gastroparesis coming to it. If it is located to the pyloric region and is hyperactive pyloric sphincter, maybe G-poem is the answer then, and not anything else. And it will allow emptying, because when there's gastroparesis, the sphincter is hyperactive at that end. And if it is really not that, then a partial fundoplication, in my opinion, or a fundoplication for that purpose may be indicated. And in extreme gastroparesis, some people, though not level 1 evidence, but there is some report out there, people actually recommend doing even a sleeve gastrectomy. Because then it actually allows food to pass through. So I think it is important to properly investigate these patients. There are a lot of medical therapies before surgery available. You can try metoclopramide, you can try domperidone, you can try erythromycin. The other drugs are not really safe. The cisapride was taken off the market because of its issues. So yeah, we have few, and we need to look into it from multiple perspectives, including medication therapy that may have caused the issue.
Yeah, that's clear. Thank you very much, Doctor. So, Sajid, do you have?
Yeah. I have a very exciting, debatable topic about the fundo failure. We saw in the literature like 20% failure after the fundoplications. And in your experience, what are the culprits which causes the failure of the procedure, in terms of the either it's a technical aspects, or the wrong selection of the patient, or the patient-related factor, and how do you approach these patients?
Okay, so I think you're absolutely right, Sajid. Since it is a shared decision making between the service provider and the patient, selection of patients and recommendations have to be based on evidence. It's not just I like or I do,
Yeah,
you
exactly.
should, I want, I don't want. Okay.
Exactly.
So really tailoring the right therapy, not even procedure. Okay. Does this patient even need surgery? Is the first question we need to ask.
Yeah.
We can tell the patient upfront. You and I know that if they respond to proton pump inhibitors, these patients are the best patients that we should be operating on. And if they have mechanical complications along with it, like hiatal hernia, they will do very good with surgery. But on the other hand, there are people who have NERD. These guys are not for surgery. Do not operate on this. You're just asking to bring the devil home to yourself, right? So first of all, we need to overcome our own biases in selecting patients to do the right thing for the right patient and making the right recommendations. Now, some people, if I go into the technical aspects, some people believe in short esophagus, that the stomach, the esophagus is actually, you can't, no matter what you do, dissect it 360 degree in the mediastinum, you cannot pull it down. If you believe one and see one, then you might want to create a neo-esophagus by the technique described and lengthen the esophagus. That's one. Then in these patients, looking for things like slip, disrupted wrap, inefficient wraps. The techniques of the wraps have been properly described in literature. If you put a wrap such that it is tight on one side and it causes axial rotation and creates a functional obstruction, it is not the fault of the patient or the esophagus or the organ. It's a technical error that needs to be corrected through understanding from barium and all that. Whether motility disorders, I would not take it. I mean, as I said, literature does not show even a floppy Nissen fundoplication results in patients with motility disorders is almost the same as like doors. If you're concerned, then obviously you can choose from the ones of the doors or the partial fundoplication, whichever would you do. I would exercise caution in patients. Look for other causes. Like eosinophilic esophagitis, achalasia cardia, all right, nutcracker's esophagus, other functional belching. Look for things like gastroparesis. Look for things that may induce reflux, like obesity. Yeah. Now you want to do anti-obesity surgery, or should you be doing anti-reflux surgery in somebody who comes with a BMI of 50? Would you want to do just an anti-reflux procedure? Yes, the patient needs an anti-reflux procedure, but you and I know that that procedure is likely going to fail even if the patient wants one. So may not be the right recommendation to make. Okay. Patients who are not willing to change their behaviors. Right? I firmly believe that here we are as service providers trying to help the patient. But the patient also needs to help him or herself for us to help them. If they're going to do all that will exacerbate reflux and they want us to fix the problem, which is directly related to their behavior, then I think it's not a win game for anybody that we come across with. So I think in all these failures that me and you experience over time, technical, progression of disease, patient factors, we all need to analyze them before suggesting more invasive therapies. I would rather constrain myself after failure unless I know that I failed for a technical reason. That's my take on it.
Thank you so much. I think just another in continuation of the same question about the wrap failures. If it's overcompetent and the patient is losing weight or and have lost a lot of weight and have gone into the malnutrition, would you consider a partial wrap, or would completely take it down and then plan in 6 months' time, or what would you advise in that?
So I think, Sajid, the first thing is prevention is better than cure.
Yeah.
Okay, so the first technical thing is make sure that your crural repair is adequate. It hugs the esophagus.
Yeah.
It does not tighten to create a groove into the esophagus. If you're not sure, there is increasing amount of data on the use of endoflip
Yeah. Yeah.
to create your wraps, to
Yeah.
create your crural thing. You can use that. The good old days is to use a 54 or 56 French bougie to
Yeah.
make sure that you don't over tighten the wrap.
Yeah.
So this is as far as prevention is concerned.
Yeah.
When you do the operation, also do not wrap in an odd fashion that it creates a functional twist
Yeah.
in the esophagus or at the gastric level,
Yeah.
so that patients don't become symptomatic. If for whatever reason, let's say it's a crural, over-tightened crural repair, you can investigate with barium, endoflip, endoscopy. There are dilators available. You can use dilatation as an approach to dilate if it's long-term after surgery. But if it's absolute dysphagia with vomiting and everything coming out, then unfortunately, sometimes you may have to go back and revise your wraps. So that's how I see it in the short and long term in my patients.
Yeah. No, that's very helpful. Thank you. Thank you.
Okay, I just have one question more. So, Doctor, for the when we check the innovation side, regarding your point of view, how do you see AI and digital tools transforming reflux management, particularly in diagnostics, surgical planning, and postoperative monitoring? Could these technologies play a key role in personalizing GERD treatment?
Okay, so that's really interesting. So we move into the days of AI. So what can AI do? AI can possibly help us better interpret data. And this could include data interpretation for manometry. It could do probably imaging analysis for endoscopy. What else can manometry, what else can AI do? I think it can put data of manometry, of endoscopy, of symptoms, and come up with precision tools that can help guide decision making. But it is as good as the data it receives.
Correct.
Okay? If it does not receive emotional data, it will not put that into equation. So again, the point I wanted to raise it is that it is an adjunct to a physician. It is not a replacement to a physician. Yeah. It is the best tool that is available to guide in decision making of available data. You know, when you evaluate something, it's pyramidal in shape.
Yeah.
Everybody agrees at 90%.
Exactly.
As you keep going up, the stakes become higher. Then the last 10% is left for the boss to make the decision. Okay, and that's where the physician has to come in and exercise his judgment and say, look, based on this data that the machine does not see, based on the logic that the machine does not have information about, I'm going to make this decision. Okay, you're going to go back to XYZ country where people have no clue about what a Nissen fundoplication is, and you're asking me to do a traditional Nissen fundoplication.
Yeah.
If you run into trouble, who is going to salvage you? Would you agree that I do a floppy Nissen fundoplication for you? Because if you, the likelihood you run into trouble is less. Even if you have symptoms, a physician can give you medicine. Yeah. Logical? AI will not take this into account.
Never.
Very good. All right. So that is one way I see AI playing impactful role. The other, I think, is for risk stratification and surveillance.
Mm.
I think the ability for AI to read imaging is incredible. It can help put things together like information on intestinal metaplasia, dysplasia, high grade, low grade, together with images from endoscopy into Barrett's, and risk stratify these patients. Oh, this guy, if you do this procedure, maybe the Barrett's will reverse. In links, we are seeing this. In fundoplications, we are seeing this. But in others, where there is already moderate to high-grade dysplasia in Barrett's, another intervention may not necessarily be needed, because the risk of development or progression to cancer is imminent. And this is where, for the novice, for where there are no multidisciplinary tumor boards, this might be of great help for these patients. Lastly, I also see this into integrating for data collection, like using patient wearables to report symptoms in the future, for mobile apps. And I think something that we have always worked with is planning surgery journeys of the patient. And this is how the entire giving guidance to patients post-surgery, where AI tools will come handy for our patients.
Thank you very much, Doctor.
I have a question as well. Like the AI is playing its role, and the technology is also booming in the last 2 decades. What do you see about, how do you forecast the future of the anti-reflux surgery in the next decade is going to be changed?
Like any disease, Sajid, that we do not know what is the prime driver. All we know that it is multifactorial. Treatment will always be multi-pronged with innovations. Magnetic sphincter device was like there before. Angel cheek prosthesis and others have been there. They will come in different forms of modifications till we nail what is causing this. And if it is again multifactorial, we will need to have multi-pronged approaches. What we can do better is to the interventions that we do, we study them better, innovate around them, like EndoFlip coming in now. Right? Like for patients, every therapy goes through a cycle of where it is minimally invasive to maximally invasive and then comes back. The wheel just keeps spinning, right? So there are therapies like TIF coming up now, great therapies. There's therapy like ARMS by Professor Inove. Maybe we just need to find that sweet spot for each patient. Where do they converge to the requirements of the patient? It can fulfill the need the physician or the surgeon sees. And as surgeons, we need to learn to say no. And as care providers, our other colleagues need to learn to say yes to surgery. So I think the paradigm will shift to disease-based management of these patients. Rather than living in our silos as surgeons, gastroenterologists, lab medicine, immune medicine, and all this, we will, for common diseases, have to come in and do a comprehensive disease management for these patients. So the decision tree in the global world will be where, like multidisciplinary tumor boards for oncology, you got to sit there and discuss, look, this guy is not going to do well with surgery. Yeah, we all agree. This guy is going to do great with surgery. This guy needs surgical intervention. That is what the forefront with AI, in my opinion, and other procedures as we develop them, even the submucosal gel injections, all this, as they evolve and get time tested, maybe One day there will be a drug that can just be so perfect for motility that we may not even have to operate. Who knew that there will be proton pump inhibitors? They came along the way. Who knew there will be GLP-1 treatment coming for obesity? It's coming. It's there. It will just get better with time. As surgeons, our aim is to help those that cannot be helped with other forms of therapy of today.
I think we are approaching towards the end time. That was a deeply enriching conversation, basic. Thank you with you. Let me see if there's any question from the audience side. No, we don't have any questions here. I'm not sure if there's any question onto the YouTube, because we are live onto the YouTube channel as well at the moment. And I think we have a last couple of minutes. Any message you want to? We try to hit all the topics in a short duration of this time. Any message for the younger surgeons, to the young physicians you want to please give?
Yeah, thanks, Sajid. So I think since this is Endoscopic Laparoscopic Society of Asia, I will address the Asian surgeons most importantly and the global surgeons. I think it is important to understand that the landscape of disease within the Asia Pacific region is actually evolving. As diet changes, as globalization happens, as climate change comes along, as stresses of life change, disease patterns are bound to change. Follow these patterns intuitively, learn from the best, apply to your population, study your population. Your population behavior may not be the same as what we get from other Asian or Western countries. Data may differ across population. If I start from Turkey and end in Japan, can we just imagine the diversity in lifestyle, diet, culture, social norms? It is just immense. From meat-based diet to purely vegetarian. From very rich carbohydrate in bread to rice. To high in vegetable to soup and noodles. It is amazing. The pots and the flavors across Asia are just phenomenal. So please do make an effort. Whatever you learn, bring back, apply, but study and share. As globalization is here and is here to stay, our people move from one place to the other, make new settlements. Humans are the biggest immigrations. We talk about the great, the great migration in Tanzania and Kenya. But we are the biggest migration. We create the biggest migration globally, moving from one country to other. And this publications of yours help us understand population behavior and treat these populations in other parts of the world and standardize therapy for these ethnic populations. And that is our strength as a community. We need to come together to understand the importance of such publications. Thank you very much.
Excellent philosophy, really. Thank you very much.
Thank you. My pleasure.
I think we can conclude the session, and I must say thank you, Dr. Amir Guldugan from Qatar for joining us, Professor Asim Shabir from Singapore for joining us, and a huge thank you especially to you for such a high-level, enthusiastic talking without any break for the last 1 hour, and to our audience as well for joining us. And thank you for joining us. Stay curious, stay current. See you next time into the next ELSA spotlight. We will propagate soon. Thank you. Thank you, everyone.
Thank you. Thank you, Sajid, and thank you, Amir.
Thank you,
Guldugan, for this nice session. We love being with you people and sharing with our